Hello, I'm Dr. Sam Goldhaber. I'm the section head of vascular medicine and the director of the thrombosis research group in the cardiovascular division at Brigham and Women's Hospital, and I am professor of medicine at Harvard Medical School. And today we're going to discuss pulmonary embolism in the intensive care unit. Here are my disclosures. And the learning objectives are risk stratification of patients with pulmonary embolism, focusing on the European Society of Cardiology guidelines, the promises that have been made about thrombolysis in pulmonary embolism, administration of thrombolysis through systemic peripheral veins at a full dose of 100 milligrams over 2 hours, or at a half dose at 50 milligrams over 2 hours, ultrasound facilitated catheter-directed quarter dose thrombolysis at 24 milligrams over 12 hours, open surgical pulmonary embolectomy, and finally bedside insertion of inferior vena cava filters without the need for radiographic imaging. We can recognize a sick pulmonary embolism patient, but to facilitate communication among our colleagues, it's useful to have a pulmonary embolism severity index, or PESI, often called the PESI score. And with this score, if you have any of the following conditions or risk factors, your likelihood of death within 30 days has been estimated at about 11%. And these risk factors include age greater than 80, cancer, heart failure, chronic pulmonary disease, tachycardia, hypotension, or oxygen desaturation. For prognostication, it turns out that an enlarged right ventricle prognosticates a potential poor clinical outcome in patients with pulmonary embolism. Ordinarily, the right ventricular diameter compared with the left ventricular diameter on the four-chamber view of the heart on chest CT scan should be about 90%. So a right ventricular diameter should be about 90% the diameter of the left ventricle. But if this increases, where the right ventricular diameter is the same or greater than the left ventricular diameter, then these patients are at increased risk of pulmonary embolism-related mortality. And in a meta-analysis of trials that studied the right ventricular to left ventricular diameter ratio on chest CT scan, it turned out that those patients who had a high RV to LV ratio on CT had a 7-fold increase in pulmonary embolism-related mortality. The European Society of Cardiology has the best overall guidelines for management strategy of pulmonary embolism patients. And patients are divided into several groups. A very high-risk group of about 5% of the patients with massive pulmonary embolism. These patients should be reperfused with thrombolytic therapy or embolectomy. At the other end of the spectrum, the low-risk group of patients has normal right ventricular size and function and has no elevation of troponin. These patients are candidates for early hospital discharge and do very well on anticoagulation alone. There is an intermediate group of about 25% of patients with submassive pulmonary embolism. Within this submassive PE group, those at highest risk have both right ventricular dysfunction with right ventricular enlargement and right ventricular hypokinesis, as well as a troponin elevation indicating right ventricular microinjury. These patients, the guidelines say, we practitioners have a choice. We can either reperfuse these patients right away or watch and wait and hold off from reperfusion with thrombolysis or embolectomy until the patients begin to deteriorate clinically. Those patients who have submassive PE who are at lower risk are those who have either right ventricular dysfunction or a troponin elevation, but not both right ventricular dysfunction plus a troponin elevation. These patients, according to the guidelines, should be hospitalized and not treated as outpatients, and they should be anticoagulated in the hospital. Now, advanced therapy for pulmonary embolism is generally reserved for patients with submassive or massive pulmonary embolism. The full dose of TPA approved by the Food and Drug Administration in 1990 is 100 milligrams of TPA as a continuous infusion over 2 hours. Half-dose TPA has become popular because there are fewer bleeding complications with half-dose TPA compared with full-dose TPA, and the dose of half-dose TPA is 50 milligrams over 2 hours. Pharmacomechanical therapy with catheter-directed ultrasound-facilitated thrombolysis uses an FDA-approved regimen of TPA 24 milligrams, usually administered over 12 hours. Another approach is taking the patient straight to the operating room for open surgical pulmonary embolectomy. And in some patients, the emphasis will be on preventing a recurrent pulmonary embolism by placing an inferior vena caval filter. Over the past few generations, a lot of promises have been made to us about the benefits of fibrinolysis in acute pulmonary embolism, including reduction in pulmonary embolism death by rapid reversal of right ventricular dysfunction, and reduction in recurrent pulmonary embolism by lysis in situ of pelvic or leg DVT, which is usually the source of the pulmonary embolism. We have also been promised that fibrinolysis can provide more rapid restoration of baseline functional status and improve quality of life compared with anticoagulation alone. And finally, we have been told that it's almost certain that with fibrinolysis we can reduce the long-term development of the devastating illness, chronic thromboembolic pulmonary hypertension. Systemically administered full-dose TPA with 100 milligrams over 2 hours got its start in 2 major trials. A trial in the United States called the USA trial, and a trial in Europe called MAPIT-3. The USA trial showed that TPA improves right ventricular function compared with anticoagulation alone, and that TPA trends toward a reduction in recurrent pulmonary embolism, and there was no case of intracranial hemorrhage. The MAPIT-3 European trial showed that TPA reduces the need to escalate therapy compared with patients receiving anticoagulation alone. And in this study of 256 patients, primarily with submassive pulmonary embolism, there was no intracranial hemorrhage. More recently, the European multinational PYTHO study was undertaken with about 500 patients receiving full-dose, peripherally administered intravenous tenecteplase, which is a fibrinolytic agent similar to TPA, versus anticoagulation alone. The primary efficacy outcome was stated in advance of the trial to be reduction of death or hemodynamic collapse in patients receiving fibrinolysis compared with patients receiving anticoagulation alone. And in fact, PYTHO achieved its primary outcome with a 56% reduction in death from any cause or hemodynamic collapse. But you see on the bottom half of the slide that this achievement in the primary efficacy outcome was offset by an increase of major bleeding. Major extracranial bleeding, usually gastrointestinal bleeding, occurred 5 times more often in patients receiving tenecteplase compared with patients receiving heparin alone. And the stroke rate, almost always hemorrhagic stroke, was 12-fold higher in the tenecteplase group compared with the heparin group. The stroke rate with tenecteplase was 2.4% of the patients, compared with 0.2% of the patients receiving anticoagulation alone. When all of the submassive pulmonary embolism randomized controlled trials of thrombolysis plus heparin versus heparin alone were meta-analyzed, it turned out that there was about a 50% reduction in mortality among patients receiving thrombolytic therapy. But at the bottom of this meta-analysis slide, one sees that the major bleeding was increased by about 3-fold in patients receiving fibrinolysis compared with those receiving anticoagulation alone. And submassive pulmonary embolism meta-analysis showed a 60% reduction in recurrent pulmonary embolism among patients who received fibrinolysis compared with anticoagulation alone, probably because of lysis in situ of thrombus in the pelvic and deep leg veins. I had mentioned that there is half-dose TPA. This was tested against heparin alone in the MOPPET trial of 121 patients. Patients received TPA 10 milligrams over 1 minute as a bolus, followed by 40 milligrams over 2 hours as a continuous infusion versus heparin alone. And with the 50 milligram half-dose regimen of TPA, there were no major bleeding complications and no intracranial hemorrhage. The estimated pulmonary artery pressures on echocardiogram were rapidly shown to be lower in the TPA group compared with the control group. This difference was noticed at 48 hours and persisted through 28 months of follow-up. Now, ultrasound-facilitated catheter-directed thrombolysis can go even further. The ultrasound-facilitated catheter-directed thrombolysis uses 2 catheters, a larger outer drug delivery catheter with side holes for delivery of TPA, and a smaller inner ultrasound core catheter which has sewn onto it high-frequency, low-power ultrasound transducers. And what you see with the outer catheter is the drug delivery of TPA through the side holes. And with the inner catheter, the fibrin strand network is first shown in the lower left-hand corner without ultrasound. The fibrin strands are thick and interwoven tightly, but the use of ultrasound, buzzing the clot, causes the fibrin strands to thin and the network to loosen. And then the ultrasound process itself causes acoustic streaming. Here we see one of my patients with two of these ECOS catheters with ultrasound-facilitated catheter-directed thrombolysis. The white arrowheads are pointing to these ultrasound cores that are sewn onto the catheter, which are buzzing the clot. And this patient is receiving 12 milligrams over 12 hours in each of the two pulmonary artery catheters. Now, the lower the dose of TPA, the lower the chance of intracranial hemorrhage. We see in the ICU study that I ran of more than 300 patients receiving full-dose TPA, the intracranial hemorrhage rate was 3%. In the PYTHO study, the intracranial hemorrhage rate was 2.2%. In the ULTIMA study, with ECOS ultrasound-facilitated catheter-directed thrombolysis, the intracranial hemorrhage rate was 0%. And in our Seattle 2 trial, the intracranial hemorrhage rate was 0% in our 150 patients. Well, I think it's fair to say that fibrinolysis fulfilled its promises over the short term. In other words, a lower death rate by meta-analysis with fibrinolysis, and a lower rate of recurrent pulmonary embolism. But what about the long-term promises and 38-month follow-up? Here we see, at 38 months, no difference in long-term mortality between thrombolysis and heparin. Chronic shortness of breath or other symptoms occurs more with thrombolysis than with heparin. But the incidence of chronic thromboembolic pulmonary hypertension is really no different between the two groups. So here I've put together a fibrinolysis report card asking the question, have the promises of fibrinolysis been fulfilled? And I think yes, the promises have been fulfilled with respect to short-term 30-day outcomes, because reduced mortality and reduced recurrent pulmonary embolism are demonstrated. For the longer-term issues, reduced long-term mortality, no benefit for TPA. Reduced long-term recurrent pulmonary embolism, no evidence for this. Reduced improved function and quality of life, no evidence for this. And reduced incidence of chronic thromboembolic pulmonary hypertension, again, there's no evidence for this. So these new findings lead to new questions. Have we focused too much on the large pulmonary vessels? Is the explanation for lack of long-term improvement that TPA did not penetrate the microvasculature? Did full-dose thrombolysis lead to microhemorrhage in the microvasculature? Well, this is not an autopsy photo. This is the result of an opened pulmonary embolectomy done surgically in the operating room by one of our cardiac surgeons. And you can see that pulmonary embolectomy is the most effective way to remove large volumes of clot. When we looked at our operative mortality, overall it was 6.6%. For massive PE, 10%, and for submassive PE, 3.6%. Here you see at the arrowheads thrombus in the large femoral vessels. The AHA, American Heart Association Pulmonary Embolism Guidelines state that inferior vena cava filters should be used when there is a contraindication to anticoagulation, or there is recurrent pulmonary embolism despite adequate anticoagulation, or there is very poor cardiopulmonary reserve, including patients with massive pulmonary embolism. And here we see the Angel, named after Dr. Luis Angel, inferior vena cava filter. This filter is inserted at the bedside in the intensive care unit without any fluoroscopy needed. So our take-home messages is that with submassive pulmonary embolism, fibrinolysis reduces 30-day mortality and reduces recurrent pulmonary embolism, but increases intracranial hemorrhage. Lower doses of TPA will in turn lower the intracranial hemorrhage rates. The fibrinolysis 3-year follow-up shows no reduction in mortality, recurrent PE, symptoms, or chronic thromboembolic pulmonary hypertension. And the Angel inferior vena cava filter allows bedside insertion without fluoroscopy. Now I'm going to ask some single best answer questions. Fibrinolysis in submassive PE, A, decreases the 30-day mortality without increasing major bleeding. B, decreases 30-day mortality but increases major bleeding. C, shows no difference compared with heparin in 30-day mortality and no difference in major bleeding. And D, increases the 30-day mortality and increases major bleeding. Are you ready? Well, the correct answer is decreases 30-day mortality but increases major bleeding. And the last single best answer question is as follows. The American Heart Association recommends inferior vena cava filters when there is submassive pulmonary embolism with enlarged right ventricle and troponin elevation, or submassive pulmonary embolism with an enlarged right ventricle with or without troponin elevation, or a massive pulmonary embolism, or recurrent pulmonary embolism despite adequate anticoagulation. Have you selected your vote? Please vote. The answer is recurrent pulmonary embolism despite adequate anticoagulation.